Well, I think we might open this session. My name's John Mackay. I will be chairing the session together with Dr. Monica Rossley, who at the moment is absent but has disappeared, but maybe just will come in in a short period of time.
Next, it's my pleasure to introduce my colleague, Dr. John Mackay, who's a pioneer of nuclear medicine here in Australia and who has decades of experience with radioactive iodine treatment. Thank you, John.
Thank you, Monica. I have changed the topic of this just slightly in the interest of time, and I'm going to talk about the role of radioiodine in hyperthyroidism. I've been in this game a very long time, and I guess the comment I make at the bottom, the more things change, the more they remain the same. The etiology of thyrotoxicosis is, of course, well known. Radioiodine only has a role in 2, 3 and 4 on that list. The management of thyrotoxicosis is threefold: antithyroid drugs plus or minus beta blocker, surgery preceded by antithyroid drugs and stable iodine, and radioiodine therapy plus or minus antithyroid drugs and beta blocker. And I guess the cynic would say, if there were really good treatment for thyrotoxicosis, there'd be one treatment. And this was the view in 1971. Now, I hate to say this was the year I started doing nuclear medicine. And in the seminars in nuclear medicine, Lewitus and Al wrote, the continuing controversy about the particular values of different methods of treatment for thyrotoxicosis proves only the inadequacy of any one of them. I don't think things have totally changed. The reason for this, of course, is related to the fact the etiology of thyrotoxicosis is still an unresolved problem. Again, that remains true. Although we know a lot about the antibodies that paradoxically destroy and stimulate the thyroid, we really don't know why those antibodies occur. Antithyroid drugs, of course, have the advantages that it avoids the damage to the gland and surrounding structures. It avoids radiation exposure. The results give you about 50% in remission in 18 to 24 months, but a considerable amount of those rebound. It can be used as long-term management. Importantly, I feel that it buys you time while the physician and the patient think about the more definitive treatment. Antithyroid drugs, of course, have some disadvantages, rash being one, but neutropenia and pancytopenia are real and can be very nasty, but they are generally always preceded by a rash. Antithyroid drugs, as I said, have a low permanent remission rate and also require frequent visits to the physician. While lucrative, it's a bit of a nuisance. Surgery has the advantage that definitive management can often be completed in about 8 to 12 weeks, including pre-surgical preparation with antithyroid drugs, etc. And really it's very good in pregnancy and in children. Surgery has the disadvantages. It's damned expensive these days to spend 3 to 5 days in hospital. There are risks of any surgical procedure, and there were 2 deaths I know in Victoria in the last 5 years post-surgical with bleeding in hospitals, around about, not major teaching hospitals, but other ones. There's a risk to the parathyroid and recurrent laryngeal nerve damage. Long-term hypothyroidism is very similar to radioiodine, 20 to 50% if you look at 5 to 10 years. The other nasty, particularly if you're a young female, is scarring. In Graves' disease, there is a definite risk of keloid formation. I've yet to meet the young female that was happy about a keloid scar across her neck. The rationale for radioiodine is the thyroid is the only tissue that retains iodine for a considerable amount of time. It's a beta emitter, that only 10% of it comes from its gamma rays. The beta only travels 2 millimetres in the thyroid tissue and doesn't affect the surrounding tissues. Hence it can be given in high doses. And the advantage is it destroys some cells, leaving others intact, thus reducing the synthesis of the thyroid hormones. It's usually definitive. It's convenient when it's done because it can be done as an outpatient. It avoids surgical treatment and these days is the most widely used treatment for hyperthyroidism worldwide. Its disadvantages are that you can get radiation thyroiditis with neck tenderness and pain radiating the jaw. I've only ever seen that with these type of therapeutic dose, i.e. what I'd call low doses, 3 times in about 40 odd years. You can get inflammation of the salivary glands. There can be a transient increase in thyroid hormone level, important when the patient's extremely thyrotoxic when you give the dose. Persistent hypothyroidism is a definite problem, and about 10 to 20% require further doses. And of course we have the long-term hypothyroidism. We use radioiodine for the following 3 indications: a hot nodule, the toxic multinodular gland, and the autoimmune thyroid disease, Graves/Hashimoto's, or a mixture. The hot nodule, of course, is the perfect one to treat with radioiodine. This patient has a hyperfunctioning nodule in the right lower pole. It's caused incomplete suppression of the rest of the gland. It's perfect to treat with radioiodine because most of the iodine goes into that hot nodule, and it will involute over about 8 to 10 weeks, and you'll end up with a patient at the end with a normal thyroid function test. If you're worried about that remnant, Professor Murray, who Monica and I will remember from our early days, taught me that you could actually give some T3 to suppress the rest of that gland if the patient wasn't too toxic. And that works very well from destroying the rest of the gland. Doesn't sound right, but it works. Toxic modular goiter requires larger doses of I131, 12 to 15 millicuries we tend to use because we've got to keep patients in hospital over 16. It's got a good effect. It can require several doses, but it also helps sometimes shrink the gland, and that can be useful in itself. And of course, the most common use for radioiodine is in autoimmune or Graves/Hashimoto's. Now, with lengthening experience, the age limit has dropped for radioiodine therapy. When I started in the game, we did not treat any woman of childbearing age. That was the thing that was drummed into us. The therapeutic people would not allow us to do this. Multiple long-term studies, however, demonstrated no increase in thyroid cancer, leukemia, or reproductive abnormalities. Radioiodine therapy is now widely used in all age groups from teenage upward. It is less clear-cut in young children. Data from Chernobyl from a 15 millicurie dose suggests a 4% increase of cancer at 5 years, 2.5 at 10 and 1% at 15. However, we're talking about not thyroid cancer but general cancer, and of course this will be contributed to by lots of other isotopes that were thrown out in that horrible accident. Sex makes no difference in how you treat with radioiodine. Hyperthyroidism is of course 5 times more common in women than men, but we know that the dose from the testicles and ovaries is low, and in all seriousness the progeny of those treated with radioiodine is normal. There are some definite contraindications to radioiodine, pregnancy, lactation being absolute contraindications. Radioiodine is trapped in the breast and gives a high dose to somebody who is lactating, a woman who is lactating. If there's a question for malignant thyroid tumour, you must go to surgery. Sometimes the patient is concerned about radiation exposure, and that must be respected. And active ectophthalmos is also a relative contraindication. I don't quite believe that, but the books do say so. Well, there were 3 goals that have been used over many years to treat people with thyroid disease. The traditional method was an attempt to render the patient euthyroid, but not introduce hypothyroidism. It usually included factors allowing for gland size, as we heard earlier, uptake and a standard dose. About 20 years ago, or 25 years ago now, there was a trend to use low-dose protocols, derived because of the high incidence of hypothyroidism with the traditional method. These days there's an alternative view around which I kind of believe in. Let's give them a big dose to begin with, make them hypothyroid or euthyroid, and avoid return to hyperthyroidism as possible. Now, we do have problems assessing results of radioiodine therapy. There is a natural incidence in hypothyroidism in Graves' disease, which is about 2.5% a year, due to the presence of antibodies in the spectrum of autoimmune thyroid disease. There is a spectrum with Graves on this side, Hashimoto's on that side, and meeting somewhere in the middle. This might be, with our next speaker, a little bit of a red rag to a bull, as we say. Calculations of doses, it seems to be an inexact science at best. Our previous speaker used palpation. Uptake is a guesstimate. Estimation of gland size and volume, even with ultrasound, can be variable. Retention of radioactivity in the gland varies from individual to individual. And I would maintain that a lot of these calculations, you multiply error by error by error to get error cubed. Not too sure it actually helps a great deal. Institutions and physicians certainly vary in the approach and philosophy how they treat it. There is definitely a variation in radiosensitivity. Young males tend to be more radio-resistant, and in my personal experience, Asian females tend to be more resistant in my own private practice. And of course, the method of administration, capsule versus liquid, I'm damn sure there's a difference between the two absorption methods, and I believe this is due to very much the intestinal hurry that people with Graves' disease get. The capsule passes through and goes through the small bowel, where iodine's mostly absorbed. Now, with the traditional method, we used a mean dose of about 9 millicuries, 7 to 10 or 12. Higher dose was based on gram weight and radioiodine uptake, a rough calculation. Problems existed still of persistent hyperthyroidism with males and very active gland. If we do that sort of level, about 40 to 50% remain euthyroid at 10 years, and about 50 to 60% are hypothyroid. With the low-dose protocol, we tried to compensate for the increased radiosensitivity of small glands and the decreased sensitivity of the larger glands, and tried to increase incidence of euthyroidism and produce lower long-term hypothyroidism. The problem with this was, again, that if we looked a year or so down the track, we still had 10% hypothyroidism, 60% were euthyroid, but 30% were thyrotoxic, generally on neomercosol, and you're going backwards and forwards wondering whether the radioiodine is going to kick in or in fact they're euthyroid because of the neomercosol. If we look 10 years down the track, we find the results aren't too much different from the higher dose. At 10 years, 40% are euthyroid and 60% are hypothyroid. Again, probably contributed to by these antibodies that run around. 25% of patients on this low-dose protocol require 2 doses and 5% 3. Now, this is expensive, it's confusing, it's lucrative for the physician if he's on fee-for-service, but it's very frustrating for the patient and sometimes for the doctor, because you can't know sometimes where you are. The high-dose protocol rationale is all attempts to produce euthyroidism by moderate doses end up with a proportion of patients hypothyroid and others with persistent hyperthyroidism requiring further treatment. The aim of this is really to make no attempt to obtain euthyroidism, but largely to destroy the gland with a high dose early, so the patient is hypothyroid early. You can introduce thyroxine replacement early and see them once a year for repeat thyroid function tests on their 100 micrograms a day of T4. This gives you near certainty of prompt control. It avoids recurrent disease. As I said, it stables the patient early on a standard dose of thyroxine. It reduces the expensive time-consuming physician follow-up and reduces the biochemical testing needed of thyroid function. I guess the bottom line is there is no right treatment, only a better one for the individual patient. I personally think it's very important to take time to know your patient and develop trust in the therapeutic relationship. Involve the patients in your decisions. Try to provide continuity. There's nothing worse in our country than outpatients where you're seen by varying doctors at a couple of monthly intervals. Provide reassurance. No matter what treatment is given, you tell your patients this illness is a hiccup in the course of life. It isn't a major disease. Explain the differing approaches to management. Give them literature and references. You might as well do this because they're all going to go straight to Dr. Google, and this way you can ensure they get something decent from the American Thyroid Association puts out beautiful patient notes, the European does, and our own Thyroid Association gives them. Definitely involve the family and partners in this decision. There is nothing more emotional than an emotional thyrotoxic. So you want to have someone calm often around them to help them and get them through that period till you get them euthyroid. Use the antithyroid drugs to buy time before making definitive decisions. Remember, none of this above will be considered cost effective by administrator or the pushers of KPIs because it does take time and explanation and careful management. Thank you.
Our final speaker for the thyroid section of this session is Professor Seigo Kinuya from Japan, who's going to talk on treatment of hyperthyroidism, the Japanese experience in therapeutic dose determination. Thank you.
Okay, thank you very much, Chairperson, for the introduction.
That's good.
I'm Kinuya from Japan. I would say Japanese situation is a bit different from the worldwide situation, especially for the percentage of the radioactive iodine therapies. Oh, by the way, I got this email from Society of Nuclear Medicine and Molecular Imaging just first this month, saying that congratulations on the radioactive iodine therapy for hyperthyroidism, and it is now 77 years old. So pretty.
Only a little bit older than me.
Okay, I know you are the pioneer in this field. Okay, anyway, congratulations on the radioactive iodine therapy. So as I already mentioned about these kind of issues by two previous speakers, and then this is a very probably impressive table for you. In Japan, only 10% of patients choose radioactive iodine therapies. When we compare to the US situation, it's quite different. And then, do you know why the Japanese patient or Japanese physicians, I mean internal medicine or neuroendocrine physicians choose radioactive iodine in such a small number?
Hiroshima.
Huh?
Hiroshima.
Yeah, I put this. Hiroshima and Nagasaki. And we have one more tragedy occurred in the Pacific Ocean. The fishermen in the tuna boat, fishing boat, was contaminated with the exposure after the nuclear test of the United States. I'm sorry for the United States. Anyway, these may be reasons. However, I don't think this is a major reason. It's a reason because of the regulations in Japan. And then up to 1998, we cannot give radioactive iodine to patient on outpatient basis, even with small dose, like 1 millicurie or 2 millicuries. We have to ask patient to be hospitalized to treat Graves' disease with radioactive iodine with such a small amount. So this is a major reason, I guess. And then in order to administer over 500 megabecquerel after 98, still we need isolation rooms to treat patient. And then reimbursement of isolation room is not good enough to be maintained. So the main hospital is going to close isolation rooms. So this is a major reason for the Japanese funny situation. And then, anyway, the number of the radioactive iodine therapy for Graves' disease or hyperthyroidism is increasing every year. And then now annually we usually treat over 4,000 patients in Japan. And then for thyroid cancer, it is climbing up to the 4,400. Anyway, now the physicians is recognizing that they can treat patient if we use a dosage below 500 megabecquerel. It's okay for the outpatient basis treatment. So now the situation is gradually changing in my country. Oh, and then we got another disaster in 2011 in Fukushima. Now, do you think this had an impact? Oh, you already know the answer. It didn't have any impact for the procedure of radioactive iodine therapies. We are so happy to see this result after this disaster. So these issues are already discussed by two previous speakers. And then I go a bit further, and then I'll show you some very strange cases I experienced. And then I personally prefer the high-dose treatment in order to avoid the recurrence of hyperthyroidism. And then this is probably the evidence I based on. Usually, when we use the low-dose therapies, the hyperthyroidism hyperthyroidism will continue for several years, and then patient is gradually be hypothyroid. So we have a long period of unstable conditions in patients. So I do not want to have this kind of unstable status. And then probably this is kind of one standard in the world. Usually people use dosage adjusted by the weight of the thyroid glands. And then I found that the first speaker's institution used the uptake of the radioactive iodine in thyroid. And then we usually use the data of the uptake percentage. And then about 15 years ago, we just summarized our cases to see how much dosage is needed to get one solution for to get hypothyroid after single administration of radioactive iodine. And then in our patient, we found when we choose the dosage greater than 150 grade to thyroid gland, it's good enough to remove hyperthyroid states after the single dose of radioactive iodine. And then to calculate this number, we usually measure the radioactive iodine uptake with iodine 123 before dosing of the iodine 131. And this is a kind of rare conditions. And professor showed us that we might see the radiation thyroiditis. However, I don't think these two cases are caused by radiation thyroiditis, because the injection of histamine receptor antagonists quickly resolve the airway discomfort. And this symptom was resolved even before the injection of steroid. So I believe that this was caused by the reaction of such kind of allergic reaction. I don't know what kind of allergen may this kind of trouble. But anyway, the fact that the histamine receptor antagonist injection quickly resolved the symptom, so I believe this was caused by the allergic reaction. And then when we administer radioactive iodine, of course, these two speakers already mentioned about these issues. And then I'll tell you some about the this let's say eye diseases and the issue of antithyroid medication. And then we know that the antithyroid drugs will have a negative impact on radioactive iodine therapies. It's true. And then we usually know that the thyroid uptake of radioactive iodine will be decreased by the antithyroid drugs. And then it's true, but how about in case of the patient treatment for the patient with a kind of let's say cardiac problem or any other problem which should not be gotten worse during the treatment session. So in some cases or many cases, I prefer to use radioactive iodine with antithyroid drugs. Probably you'll object to my ideas, but in order to get a stable condition during the radioactive iodine therapies, in my opinion, it is quite necessary to make patient condition stable. I mean, I do not want to make hyperthyroid worse in a session of radioactive iodine treatment. So in order to get enough response from the radioactive iodine therapy, I just simply increase the dosage, right? And as I told you, the 150 gray is probably good enough to treat patient, but when I combine with the antithyroid drugs, I usually use 250 so that I can get a good response from patients. Probably this is a kind of one solution to use this kind of strategy. And then thinking about the ophthalmopathy, you know, I usually, not usually, sometimes I use the steroid when we administer radioactive iodine, especially in patients with some mild eye problems. And then we got two very strange eye problems after the therapies. I mean, this patient was transferred to our hospital, and then I took over this patient around 2011 or 12 from my senior doctors. And then see, this patient obtained hypothyroid in 2013. And then 5 years later, suddenly this patient complained the eye problems. And then I sent to the Department of Eye Doctors. And then they told me, wow, this patient had a problem of the Graves' disease in eyes. And then see, the TSH antibody is not so high. So I was surprised to see this patient, and probably this is a pretty rare case. However, it may happen in your patients. So we have to be really careful about the eye problem in patients. And then this is a very strange case. This patient is a papillary thyroid cancer and a follicular thyroid cancer, duplicated. And then he got a total thyroidectomy in 2004, and then 5 years later, he got the ablation dose of 100 mercury. So this means no thyroid tissue remain in this patient. And then there's no evidence of recurrent disease or residual diseases. And then 2 years after the ablative dose, she complained double visions. And then again, I sent her to the eye doctors. And then they found it was Graves' disease. And then see, in this case, high TSH receptor antibody exists. I don't know why. Without any thyroid tissue, this patient has this high titer of antibody. So probably nobody experienced this type of eye problem in patients. Anyway, this kind of funny things happen in real world. And then this is a very unusual case of Munchausen syndrome. Do you know this syndrome?
Yep.
Yeah. And then in Japan, we administer radioactive iodine in a capsule form. Now, we do not get a liquid form of radioactive iodine. And then I did give her the capsules. And then I just let's say 5 minutes after I left her isolation rooms, he spit it out into the garbage can. And then I usually measure the uptake after 24 hours after the administration, and then I found nothing there. Yeah, of course, some radioactivity is there. However, it's just close to the background levels. And then I searched her rooms, and they found high activity exists in the garbage can. It was something funny story, but this may happen for your patients. And yeah, you know this. So this is the last slide of my talk. We Japanese Society is going to hold next meeting of World Federation in Kyoto. So you are welcome to come to Kyoto to attend this meeting. Thank you very much for your attention.
Okay, our final talk for this session is from Professor Belkıs Erbas, who's come all the way from Turkey, from Ankara, and she has an interest in both renal disease and oncology, and she's going to talk on the complementary role of renal nuclear medicine in oncology. Thank you, Belkıs.
Thank you, Monica. I will talk on the renal function measurement in oncologic patients. I have no disclosure. And in my talk, I will first define the renal function impairment and grading of the renal function impairment and toxicity in patients. And then I will talk on the renal function impairment in chemotherapeutics and radiolabel therapies. Kidney injury may be in 3 different forms, maybe prerenal, intrinsic renal, and postrenal. In every 3 forms of the renal injury is possible in patients with oncologic abnormalities. Renal function measurement is important, significantly important in oncologic patients because if there is a decrease in the renal function, it limits the efficacy of the therapy, either chemotherapeutics or other kind of therapies, and there is also effect on the survival of the patient. It decreases the survival, and the most important is the quality of the life. With a decreased renal function or with a dialysis, with the need of dialysis, the patient will have a very poor quality of life. Actually, effect of the malignancy can be either direct or indirectly on the kidneys. In the direct effect, primary tumor of the kidney or collecting system may affect the kidney function, and invasion of the kidney is possible by the tumor. And indirect effect is due to the therapy and other complication, either with chemotherapeutics or radiation, and the other complication which may contribute to the functional decline of the kidneys. When we look at the reasons for the functional impairment in the oncologic patients, the invasion of the kidney, obstruction due to the mass effect of intra-abdominal or pelvic kidney, mainly in the gynecologic tumors, bladder tumors, and also prostate cancer. Tumor lysis syndrome can be resulted in the acute kidney injury. Radiation therapy, external or internal, can also result in the kidney failure and kidney decline in the renal function. Intravascular volume depletion can also decrease the renal flow and then renal functional impairment. Concomitant use of chemotherapeutics and other drugs which are toxic to the kidneys are also another reason. Contrast material toxicity can be also another reason. And these patients has a very large variety of the symptoms. It may be from asymptomatic creatinine increase to the renal failure, which is in need with dialysis. In this talk, I will focus on the assessment of functional impairment, and the question in the clinical setting is can we predict renal toxicity? Actually, it is difficult, and how we have to measure the renal function and how we can follow up the renal function. Actually, all you know, renal function can be measured by either endogenous marker, or we can use estimated GFR measurement, or we can use radionuclides. This is the more accurate method. Creatinine is the very practical marker for the renal function. It is cheap and easy, and it's available in in all centers, but its level is influenced by the muscle mass, nutritional state, and inflammation. Anti-cancer drugs can alter the correlation between the GFR and the creatinine clearance. Because of this reason, it should be used carefully. Its sensitivity is insufficient in moderate GFR reduction because of the tubular secretion of the creatinine, and it may be normal even with GFR values higher than 60 to 90 ml per milliliter. Cystatin C is another marker, but it is not used routinely. It is sensitive in mild reduction of GFR between 60 to 90 ml per minute. There are different formulas to estimate the GFR using serum or plasma creatinine levels. Most commonly known is Cockcroft and Gould formula. There are also other formulas: modification of diet in renal disease formula, and chronic kidney disease epidemiology collaboration formula. These formulas are the most commonly known, and it is used to estimate the GFR. However, it is known, and it has been shown in many articles, that measured GFR using radionuclides methods is superior to the estimated GFR methods. However, these are practical, easy, and cheaper to compare the radionuclides methods. We know that gold standard for the GFR measurement is the inulin clearance. However, it is expensive. It is not easily available everywhere. It is a time-consuming method, but it is the gold standard. Unfortunately, it is not used in the routine practice. 51 chromium EDTA is the second better radio tracer or method to measure the GFR, but it has also some drawbacks. For example, multiple sample is needed, well counter and laboratory process is needed, and we cannot obtain any image, and we cannot measure the split renal function. However, it is almost the gold standard in many research articles and in clinical trials. DTPA is the easiest and cheaper way to measure the GFR. However, attenuation by soft tissue and inaccuracy of using geometric mean and extracellular localization of the tracer and the variable protein binding is drawbacks to measure GFR. There are different GFR measurement methods using either single sample method or two sample method or three sample methods. There is also gamma camera GFR measurement methods, but it is not very accurate method, and it is not recommended to use for the GFR measurement. To describe the toxicity of the kidney, there are different definitions of the renal failure or renal function impairment, and these are published by several different organizations. Most commonly in the radionuclide therapies, this system is used. Common terminology criteria for adverse effect events. It is published by the National Cancer Institute. They have two different grading systems for acute kidney injury and also for the chronic renal failure, chronic impairment of the renal function. They have a 5 level of grade, and they use the creatinine level as a reference. In the grade 4 and grade 5, They described it as a very serious, clinical significant renal toxicity levels. When we look at their another grading system, chronic kidney disease, for the chronic kidney disease, in this grading system, they use the estimated GFR values or creatinine values, and again it is 5 grades, and grade 4 and grade 5 are the clinically significant grades, and dialysis or renal transplant is indicated. For the by the International Society of Nephrology, there's another definition and grading system for the acute kidney injury. For the chemotherapeutics, mainly this grading system is used. Again, they use the creatinine as a reference value, and there are 3 stages: stage 1, stage 2, and stage 3. According to the National Kidney Foundation, another grading system for the chronic kidney disease, and they also use GFR values. Mainly it is used the estimated GFR based on the creatinine clearance. However, we know that estimated GFR are not accurate compared to the radionuclide methods. In oncology, chemotherapeutics are used, and some of those has a toxicity on the renal system because their major elimination pathway is by the kidneys, and not only those drugs but also antineoplastic agents, and also their metabolites are also cleared by the kidneys. Main mechanism is the glomerular filtration and tubular secretion. Because of this reason, glomerulus, tubules, interstitium, and microvasculature have the influence from these toxic agents. Most of those are potentially nephrotoxic. And nephrotoxicity is a dose-limiting complication. Because of this reason, it is important, according to the level of the renal function, dose should be adjusted. If there is a lower GFR, and chemotherapeutic dose should also be adjusted for a lower doses. Most common nephrotoxic agents are those platinum derivatives, mainly cisplatin and carboplatin, alkylating agents, ifosfamide, and antimetabolites, vascular endothelial growth factor pathways inhibitors, and epidermal growth factor receptor pathway inhibitors have also toxic effects on the kidneys with different grades. When we look at the structure of the glomerulus and the tubules, their effects, the toxic effects of chemotherapy may be on the different part of the glomerulus and the tubules. The cisplatin is the most commonly known toxic chemotherapeutics, and its effect is on the tubules. Cisplatin is used in many tumors in combination with other chemotherapeutics. In 24 hours, more than 50% is excreted into the urine, and its concentration in the cortex is several-fold greater than the plasma, and its toxicity is on the S3 segment of the proximal tubule. And as a result, there is a decrease in the GFR in those patients. Vasoconstriction in the renal vasculature is the main problem at the beginning, because there's a decrease due to the vasoconstriction. Pro-inflammatory effects has also contribution to the renal impairment. Acute kidney injury is seen in those patients. This injury can be either progressive and may be irreversible. In one study, approximately 1/3 of the patients had a decline in GFR at the beginning, around 10 ml per milliliter. In this diagram, you can see the acute kidney injury can be seen in 2/3 of the patients. Here you can see. But when we look at the stages of this complication, about half of the patients has a stage 1 toxicity, lower grade of toxicity. and stage 2 and stage 3 here you can see. In the follow-up, in this study, estimated GFR are used. At the treatment, there is a decrease in the GFR, estimated GFR, and then after 1 month and 12 months following therapy, there is slight increase again, the GFR values, but at the end, there is significantly decreased GFR in patients with high grade of acute kidney injury. This is the high grade of acute kidney injury, and there is no recovery of the kidney impairment in those groups. There is a study which compare the estimated GFR and creatinine values with comparison with EDTA values. You can see here, this is the therapy period, this part, and this is the follow-up period. We can see the creatinine levels here, creatinine levels, and these are the calculated GFR values. During the therapy, there is a decrease using the both method, but after that, during the follow-up, up to 2 years, creatinine values are normal, but GFR values, actual GFR values, still very low. It shows us that there is an overestimation of the renal function using creatinine values. Because of this reason, especially in patients with nephrotoxic chemotherapy, creatinine values should not be used as a monitoring purposes because they overestimate the renal function, and we cannot find the real patients with renal toxicity. When we look at the correlation between the GFR and creatinine values, here you can see there is a correlation at the beginning, but after that this correlation is lost. It means we should not use the creatinine values. It is not correlated anymore. It doesn't show us the real renal function level. Another study, again, it is a comparison between EDTA measured GFR values and estimated values. At the beginning, there is a correlation, not very good correlation, but there is a correlation. But after therapy, here you can see creatinine values. This is the creatinine values. These are the estimated GFR values, and this is the actual calculated GFR values. Again, creatinine values and also estimated GFR values are or overestimated the real renal function. Another study about with carboplatin in patients with therapy with carboplatin, a dose estimation should be done using the colored formula. And however, if there is no real correlation between creatinine and GFR, then application of this formula will be wrong. And in this study, an overestimation in carboplatin dose was seen in 81%, 87%, and 66% of the studies using MDRD formula, CKD formula, and Cockcroft formula. It means these patients received higher doses which they need actually. And then I will continue with radiation toxicity because it is related to our applications. It can be radiation toxicity, can be either by external beam radiation therapy or therapy with radio-labeled radiopharmaceutical. Theranostics are very popular now. Actually, there's a 20 years history of theranostic, but in this day, with lutetium and yttrium, it is possible to treat the patient with neuroendocrine tumors and also prostate cancer. And in many centers it is available, and there's a very big interest to those therapies. However, kidneys are the critical organs because there's a high uptake of this tracer in the kidneys due to glomerular filtration of the tracer, and then the tubular reabsorption by the proximal tubules. And there is also interstitial retention of the tracer in the kidney. After injection of the tracer, approximately 4% of the total activity is reabsorbed by the tubules, and it retains in the tubular cells. It has been shown that this uptake, tubular reabsorption of the radiolabeled peptides, is mediated by the megalin-kubulin transport system. Here you can see the transportation into the tubular cells is mediated by this system. To decrease the uptake of the tracer by the kidney, there is two different ways. Either we can use positively charged amino acids, or we can also use gelofusine, which inhibits these pathways. And approximately 40% of the tracer is decreased using amino acid infusion, and with gelofusine, up to 70% of the tracer uptake can be decreased. Here you can see a gallium-68 dotatate PET-CT imaging in a patient with bronchial neuroendocrine tumor. This patient has bone metastasis, and there is a high uptake in kidney, you can see. And then when this patient received 4 cures of the therapy with lutetium, you can see again there is a very high uptake in the kidneys. In radiation nephropathy, histopathologic changes can be seen, but mainly thrombotic microangiopathy and tubular interstitial scarring atrophy is seen. Radiation nephropathy can be occur in two forms, either acute radiation nephropathy or chronic radiation nephropathy. Acute radiation nephropathy occurs with higher doses, more than 25 grays. It can be there can be spontaneous resolution, or it progresses to the chronic nephropathy, and this acute form can occur within 6 to 12 months after the irradiation. Chronic radiation nephropathy occurs due to the lower doses of radiation, and it occurs after 1 to 5 years after the exposure. Most of the information came from the experience with the external beam radiation therapy. According to the studies, 23 gray cause renal failure in 5% of the patients, but it is not linear. There is no linear relationship between the dose and also the nephropathy. With 28 gray, 50% of the patients has the renal failure in 5 years. Therefore, lower doses is accepted as a safe in radiation therapy, external beam radiation therapy. 15 to 70 gray with 2 gray fraction is considered as a safe. In nuclear medicine or radionuclide peptide therapy, there is no real accepted threshold, but according to the result of the studies and dosimetric studies, biological effective dose terminology is used, and lower than 30 gray was accepted as a safe in patients without any risk factor, but in risk factor, this threshold should be less than 28 gray. For the description and the grading of the PRRT-related nephrotoxicity, commonly common toxic criteria for adverse event criteria is used, and grade 4 and 5 nephrotoxicity is reported after 14% of the patients. Risk factors are important because these kind of nephrotoxicity is seen mainly in patients with risk factor, older age, pre-existing renal disease, hypertension, diabetes mellitus, previous nephrotoxic chemotherapy, metastatic lesion close to the renal parenchyma, and single kidneys are important risk factors. There is also another factors related to the therapy type and application type of this therapy. Choice of radionuclide is important. Either lutetium or yttrium can be used, but lutetium has a lower toxicity, or it is said that lutetium has a lower toxicity because of its short half-life and because of its lower energy. Cumulative radiation dose to the kidneys is also important. Renal radiation dose for per circle is also important. Activity administered and number of cycles and time interval between cycles are other factors. Actually, we can use the renal function using radionuclides before and after radionuclide peptide therapy, either with EDTA or DTPA, or we can also use MAC3. When we use the DTPA, we can use GFR measurement, and also we can use split renal function. MAC3 gives us the tubular extraction rate, and also again we can use split renal function, but EDTA is the most accurate method for the GFR measurement. When we look at the yttrium labeled PRRT, high-grade toxicity is up to 14%. However, low-grade toxicity is up to 50% in the patients, and estimated GFR decline in the patients up to 2 years is reported as a 9.2%, and in the longer follow-up periods, it is slightly lower. When we look at the creatinine and eGFR values in another study, it was reported 4.5% toxicity, high-grade toxicity. In one study, estimated GFR and measured GFR with EDTA was compared, and they show that estimated GFR is overestimated the renal function, and it is more pronounced in lower GFR values. And these methods, creatinine or creatinine-based GFR estimation, may lead to underdiagnosed low-grade toxicity and mild early changes. The mean decline in GFR has a progressive loss during the follow-up. It was 12 ml in the 3 months. However, there's an increase in the decline after 1 year. It's the progressive toxicity. Because of this reason, we have to follow up the patients carefully for a long time. Okay. With lutetium, the toxicity is lower. However, in some studies, it was reported the similar toxicity rate with yttrium and lutetium. According to the guidance prepared by the ENM and SNM, it was recommended that GFR measurement using DTPA and EDTA should be used, or tubular extraction rate measurement can be used using the MAC3, especially in patients with risk factors for the long-term nephrotoxicity. Okay, thank you very much.
Yes. I'd like to thank the speakers, including myself, for excellent presentations. And,